Good morning. Today we are going to have a very important webinar on leprosy. This will be a series of lectures in the coming months. So basically we will start with the clinical features and then go to the other aspects of leprosy. Even though leprosy is eradicated from Kerala or India, we are coming across leprosy patients, not rarely, but we are having some difficulty in diagnosis. This is because we are not exposed to leprosy. Of course, government medical colleges may have a good number of leprosy cases. The private medical colleges, as such, the leprosy is not very much seen. And we are having difficulty in treating leprosy patients because in Kerala, rifampicin is under government control and rifampicin is not available freely. So we have to refer the patients to government medical college for treatment. So in that scenario, we have to learn leprosy because a miss of leprosy may have far-reaching implications. I mean, of course, the deformity, that is the most important problem of leprosy. And this deformity may set in quickly if you are not seriously considering leprosy in a case. Especially in childhood leprosy, there is frequent exacerbation, that is reactions in leprosy. And if you are not going to address reactions in leprosy, that may cause problem. So in this context, the present day postgraduate trainees should have a good understanding of leprosy. That's why the webinar is. So today we are going to have first talk on leprosy. It is by an eminent dermatologist and professor of dermatology. She had a good experience in dermatology and when she was a student, she was very good. And over to you, Dr. Shwetha.
Thank you, sir. I'm very grateful to you, sir, for giving me this opportunity to talk on the clinical features of leprosy for all the postgraduate students all over India. Okay. So let us begin a discussion.
Go ahead.
Yeah. So let's begin the clinical features of leprosy. So like Crichton sir said, it is very important to know the clinical presentation of leprosy. You know, there is a varied presentation of leprosy. This is because of the spectral nature of leprosy, right? So we have to have a good understanding of the spectral nature of this disease and be able to identify the clinical features of leprosy and make a proper diagnosis. Okay, so coming to leprosy. As you all know, Hansen's disease or leprosy is caused by, it's a chronic infectious disease which is caused by Mycobacterium leprae. So this organism, it is a gram-positive obligate. Obligate meaning it needs a definite host to complete its life cycle. Okay, and this is an intracellular microorganism which cannot be cultured in artificial media. And so this has a varied clinical picture. Okay, it can range from an insignificant area of hypopigmented skin that heals spontaneously to widespread damage that can occur to the peripheral nerves, eyes, bones, muscle, and various other organ tissues. And it can lead to even deformity and disability. So this is based on the result of host response to the presence of bacilli rather than of the changes directly due to bacillary invasion. Okay, this is the result of how the host immunity responds to the presence of the bacilli. Okay. Okay, and then what you have to understand is that only a proportion of the affected individuals develop signs of leprosy after a usual it has a long incubation period of about 3 to 5 years and even more. And sometimes it can just remain as a subclinical infection. Okay, so that is what only a proportion of individuals affected may develop signs of this disease. And this is the only human pathogen which is capable of invading the superficial peripheral nerves. Okay, so this disease has a predilection mainly for the skin and the nerves. Okay, and so this peripheral nerve involvement, how does it occur? From the leprobacilli heterogeneously spreads and goes and colonizes the epineural vessels, and finally the endoneurium, and the target organ is the Schwann cells. Okay, so the Schwann cells are affected, and the subsequent fate of the disease depends upon the resistance offered by the or produced by the infected individual. Okay. So what is the etiological agent? This is an acid-fast bacilli. This is called because of the acid fastness property of this bacilli. That is, it while staining the bacilli, it resists decolorization, which is already stained primarily by the carbol fusion. It resists decolorization. So this property is known as acid fastness. Now, what is the etiological agent? So we all know that Mycobacterium leprae was the organism identified, which was described in 1873 by Norwegian physicist Gerald Hansen in Norway. And the second causative agent was also identified in the year 2008 by Hans et al. That is known as the Mycobacterium lepromatosus. And this lepromatosus was identified in red squirrels in the Scotland. Okay, so there are two causative agents for leprosy now. One is Mycobacterium leprae, and then there is Mycobacterium lepromatosus. Now, because of the spectral nature of leprosy, okay, that we need to classify leprosy for better understanding, to make a diagnosis and do a proper management. So for this, we have the well accepted classification. The first and foremost, you have the Ridley-Joplin classification, and the second one is the WHO classification. So Ridley-Joplin classification is the most scientific and widely accepted one. And this is based on 4 important features, that is the clinical features, histological features, bacteriological features, and immunological features. And this has been subdivided into 5 groups. So you have the tuberculoid, also called as TT, borderline tuberculoid, BT, mid-borderline BB, borderline lepromatous, BL, and the lepromatous leprosy, LL. And what you have to know is that the TT and the LL, tuberculoid and the lepromatous leprosy, are immunologically stable, while BT, BB, BL are unstable. So they can downgrade or upgrade. And the lepromatous leprosy is further divided into polar type and the subpolar type. So this means that polar type means it is the stable type. That is, it starts as lepromatous leprosy, and they do not downgrade. They can remain as lepromatous leprosy itself. It is most stable type. And the second type of lepromatous leprosy is the subpolar type, which is the unstable type. So they have usually downgraded from the tuberculoid spectrum towards the lepromatous spectrum. So that is a downgraded form, and this type is highly unstable, and there is increased chance of reactions. Reactions means immunological episodes of reactions that can occur in the course of leprosy. Next is the tuberculoid type. In the tuberculoid type also, you have two divisions, that is the polar tuberculoid and the secondary tuberculoid. And here the difference from the lepromatous type is that both are stable, okay? So tuberculoid type polar, it starts in tuberculoid leprosy and remains as tuberculoid leprosy throughout. But the secondary tuberculoid is an upgraded form from the borderline tuberculoid, but this is stable, unlike the subpolar type of lepromatous leprosy. And there are two important types of leprosy, which is the pure neuritic type and the indeterminate type. All this we'll be discussing in the coming slides. And what you have to know, this is missed by the Ridley-Joplin scheme. It's not included in the Ridley-Joplin scheme. Then you have the WHO classification. And this classification was to determine the appropriate therapy for leprosy patients. And we follow the 2017 classification. And this is classified into two types, that is paucibacillary type and the multibacillary type. So when do you call a case of leprosy as paucibacillary? If you have a leprosy with 1 to 5 skin lesions without any bacilli on skin smear, okay? Without presence of bacilli on skin smear. And the next type, is the multibacillary. When do you call a case as multibacillary type? A case of leprosy of more than 5 skin lesions or with nerve involvement or neuritic pain, or any of this is enough. A case of leprosy with more than skin lesions or with nerve involvement or any number of skin lesions or with demonstration of bacilli in a slit skin smear, irrespective of the number of skin lesions. Okay. So these are the cardinal features of leprosy. So what is the definition of a case of leprosy? A case of leprosy is defined as an individual who has not completed the course of treatment and has one or more of the 3 cardinal signs. That is, first sign is a hypopigmented or erythematous skin lesions with definite loss or impairment of sensation. And the second one is involvement of the peripheral nerves as demonstrated by definite thickening and impairment. And the third one is slit skin smear positivity for acid-fast bacilli. So any one of the 3 cardinal features is enough to make a diagnosis of leprosy. So this is very important. So now what is the nature of leprosy infection? So nasal mucosa is the main entry of the bacilli, okay? So the acid-fast bacilli, Mycobacterium leprae, it invades the nasal epithelium and it goes to the lungs, respiratory system, and from there to the bloodstream, hematogenous spread, and it causes widespread infection. And this based upon the immunity. That is, so what is the immunity that plays a role here? This is cell-mediated immunity. Okay, so if you have a good cell-mediated immunity, the system tries to confine the leprosy bacilli to a point. So that leads to the localized nature of the disease that you get in tuberculoid spectrum, tuberculoid leprosy. Okay, so you get asymmetrical lesions in tuberculoid spectrum. And if the cell-mediated immunity is poor, and the leprosy bacilli starts to increase in number, and it leads to widespread spread of the disease, leading to symmetrical involvement of lesions all over the body in the lepromatous spectrum. So this is the spectrum that extends from tuberculoid leprosy towards and it moves towards the lepromatous pool. And this is based upon the cell-mediated immunity. So towards the tuberculoid pool, you have a very good cell-mediated immunity. So cell-mediated immunity is important as this bacilli is especially a intracellular pathogen. Okay, it attacks the macrophages. So you have a very good cell-mediated immunity. It tries to confine the disease and it does not lead to a widespread involvement. Okay, and as you shift towards the lepromatous pole, you have a humoral-based immunity. So humoral-based immunity, that is the B cell mediated, it doesn't have much of a role in containment of the disease in leprosy, and that leads to widespread nature of disease of leprosy. Okay, so towards the lepromatous spectrum, you have a very poor cell-mediated immunity. Also, there are two reactions that are described in leprosy. So you have type 1 and type 2. Type 1 is the reversal, also called reversal reaction. If the disease downgrading or reversal reaction it is called. That is from the lepromatous spectrum of disease. It shifts towards, downgrades towards the tuberculoid leprosy. It is usually seen with starting of MDT. And then you also have a downgrading type, okay? That is from the tuberculoid pole towards the lepromatous pole. Then type 2 reaction, also called as erythema nodosum leprosum. And this is an immune complex deposition disease. Okay, so the reaction will be dealt in the next class. Okay, so moving forward. So next about the immune zones in leprosy. So these are relatively spared zones in a patient with leprosy, and this sparing is not per se because of the immunity of the patient. It is because of the because the Mycobacterium leprae has a predilection for cooler areas, okay, cooler areas of the skin. The warm areas are generally spared. This is because Mycobacterium leprae prefers a growth temperature less than 37 degrees Celsius. As a result, scalp, groin, axilla, perineum, these are all hairy areas, and they are relatively warmer. Transverse band of skin over the lumbosacral area. So these areas are all relatively spared. Okay, so importantly, I'm telling you, these are only relatively spared. It's not a must that these areas are never affected. They can get affected, but relatively spared because of the warm temperature. Okay, and the next, palms and soles have also been included by some authors, and this because of the thick epidermis and fibrofatty tissue, which provides a insulating property to this area, and also because of the increased nerve bed temperature. Okay, so palms and soles are also relatively spared. So this is meant by immune zones in leprosy, the relatively spared areas. So now let us move on to the clinical presentation. So what are the earliest clinical presentations seen in leprosy? So it could be just an area of numbness over an area of skin. Sometimes there can be skin lesions, macules, papules, plaques, and so it could be anesthesia of a extremity. It could be neuritis, nerve pain and tenderness along the nerve. Sometimes patient may present with reaction, okay, features of reaction. And in lepromatous leprosy, the earliest feature, clinical feature, is edema of the feet and nasal symptoms, which are often missed by the patient. They do not report to the doctor at the earliest, so we miss to see this clinical picture. So nasal symptoms like stuffiness, crust formation, and epistaxis can all be seen. These are the early presenting features seen in leprosy. And the late presenting features, patient because of nerve involvement, the anesthesia of the nerves, and muscle paralysis. So patient may come to us with weakness of hands or face. They may present with deformities or resorption of fingers or toes, or trophic ulcers, that is in an anesthetic hand or feet. So these are all the late presenting features of leprosy. So as I told, the lepra bacilli mainly affects the skin and the nerve. So it's very important to know about the nerve examination, okay? So how do we examine the peripheral nerve? So you have to palpate with the pulp of the finger and not the tip, okay? Always palpate across the course of the nerve to know any irregularity in the surface of the nerve, any nodularity. Always make sure to compare both sides together so you can see if there is any nerve enlargement when compared to the other. So this is the WHO of nerve thickness. So you have grade 0, 1, 2, and 3. Grade 0, there is no nerve thickening. It feels normal. Grade 1, you have mild thickening when compared to the contralateral side. And moderate thickening, grade 2, thickening is rope-like consistency. And severe thickening is grade 3, where you have nodularity or beaded appearance of the nerves. So these are some of the peripheral nerves that we examined. So first, peripheral nerves and the cutaneous nerves also has to be examined. So first, the picture depicts the examination of the supratrochlear nerve along the medial aspect of the eyebrows, and also you have the supraorbital nerve. Picture shows the examination of infraorbital nerve in the infraorbital groove. Then the great auricular nerve, you ask the patient to tilt the head to one side, and you can see the great auricular nerve across the omastoid, so you can palpate it. Radial nerve at the radial groove behind the insertion of the deltoid muscle. Then you have the ulnar nerve at the ulnar groove between the olecranon process and the medial epicondyle. Then the median nerve at the proximal area of wrist beneath the palmaris tendon. The radial cutaneous nerve at the wrist at the lateral border of the lower lateral border of the radius, you can palpate. Common peroneal nerve, it winds around the neck of fibula. You can palpate there. Sural nerve at the insertion of the gastrocnemius muscle, and posterior tibial nerve behind the medial malleolus. So nerve examination is very important. Okay, so there are 8 important characteristics of leprosy that is useful in the classification. So these features help us to know where the disease lies within the spectrum. Okay, so based upon the number of skin lesions. So if you have a higher cell-mediated immunity, the lesions will be fewer. Okay, the immunity tries to kill the bacilli and contain the disease within a area. So you have very few number of lesions. So this is seen in the tuberculoid spectrum. And as you move towards the lepromatous spectrum, you have numerous lesions. Now, next point is the distribution and symmetry. So obviously, when the lesions are few, the leprosy lesions are confined to an area. Next is the definition and clarity of skin lesions. The more readily a lesion can be seen and defined, if it is well defined, nearer it is to the tuberculoid pole. Next point is anesthesia. Greater loss of sensation in a skin lesion and more rapid anesthesia seen in response to a peripheral nerve damage, the greater is the degree of cellular hypersensitivity. So towards the tuberculoid pole, you have a greater loss of sensation, and in the lepromatous spectrum, initially there will not be much of a loss of sensation, but in the late leprosy, you have diffuse loss of sensation. Next point, the loss of sweating and reduced hair growth. So this is due to the autonomic nerve damage, and this can occur early in paucibacillary, that is the tuberculoid spectrum, and late in the multibacillary. The distribution, extent, and nature of peripheral nerve involvement. When cellular hypersensitivity is present, nerves are thickened and become more damaged quickly. So nerve thickening is more pronounced, and large nerve trunks are all involved in case of tuberculoid leprosy rather than in the lepromatous spectrum. Also, pointing to the mucosal and systemic involvement, paucibacillary disease affects only the skin and nerves, peripheral nerves. In multibacillary, especially the lepromatous type, the disease, there may be invasion of, there can be rapid cell damage, and it can invade muscles and various other systems like testes, eyes, muscles, lymph nodes, tendons, and bones. And the number of Mycobacterium leprae, which can be demonstrated by the slit skin smear examination. The bacterial index also helps us to classify the disease. So you have a higher bacterial index in lepromatous leprosy. So in higher immunity, that is in TT-BT, you have few countable lesions, asymmetrical nature of disease, well-defined and regular border plaques, anesthesia, hair loss, and hypoanhidrosis, and asymmetrical nerve involvement. And in the lower immunity, that is in the BL and LL, you have numerous lesions. They are symmetrically distributed and papules with ill-defined borders, hypo or normo-aesthetic. Many peripheral nerves are symmetrically enlarged. And in the mid-immune, in the borderline spectrum, you get features of both spectrum, that is the TT spectrum and LL spectrum, and they are highly immunologically unstable and are prone to reactions. Now let us move on to various types of spectrum. What are the different types? So indeterminate leprosy, this has been described in the Indian classification. This is not included in the Ridley-Joplin classification. So here, the lesions that develop before the host mounts a definite immunological response. So that is meant by indeterminate leprosy. So this is the very common type of leprosy seen in India, the first sign of disease seen in 20 to 80% of the patients, and they are most common in children. So how do they present? So you get one or a few ill to well-defined hypopigmented or faintly erythematous macule. So they are ill to well-defined, okay? Irregular. You can see an irregular hypopigmented macule. And the surface will be slightly dry when compared to the normal skin. And what are the common sites affected? The extensor surface of the limbs, face, or buttocks. There may be slight hypoesthesia, but most of the time the sensations are intact. The slit skin smears and lepromine test. So lepromine test looks for the cell-mediated immunity. So if you have a good cell-mediated immunity, lepromine test is positive. But here that is negative. Even you will not able to find any bacilli in the smear. And histamine test will be you get very reduced or absent Wieland flare reaction. And what is the cause of the disease? Most of the time they may heal spontaneously, but 30% may progress to a determinate type, and this is most usually the lepromatous spectrum. Okay, if they are progressing, usually 30% it moves towards the lepromatous spectrum. And the prognosis with treatment is excellent. Usually there will not be any reactions or neurological sequelae. So early identification of this disease is important. And what are the differentials? So as you all know, leprosy is a great mimicker. All type of morphological presentation can have varied differential diagnosis. So in case of an indeterminate leprosy, it may mimic a pityriasis alba, a hypopigmented macule that can mimic a pityriasis alba or a hypochremic variant of pityriasis versicolor, post-inflammatory hypopigmentation, achromicus, nevus anemicus, vitiligo. So these are all the various differential diagnoses for indeterminate Hansen's. So the next type is tuberculoid leprosy. So here, skin lesions are often single or few in number, usually less than 3 number of lesions are seen. And the single lesions, they are larger, up to 10 centimeter in diameter. And the characteristic features of the lesions, they are well defined, they are asymmetrical because there are very few number. And they may be plaques, which are erythematous or copper colored, homogeneously elevated borders, and they gradually flatten towards the center. So this characteristic presentation is also called a saucer right way up. Okay, so like a saucer, the borders will be elevated and towards the center, they will be depressed, okay, or flattened in the center. So like a saucer. And sometimes macules may also be seen, and they are well-defined erythematous or hypopigmented. And the surface of the lesion will be dry and scaly with complete loss of hair and sweating. Okay. And so the autonomic nerve damage is high here, and there will be complete loss of sweating and loss of hair. Sensory loss also over the lesion is severe and may include all 3 modalities of sensation will be affected: pain, touch, temperature. Either none or a single nerve may be thickened, and this is usually probable in the vicinity of a tuberculoid lesion. Now coming to the slit skin smear for AFP, this is negative. Lepromine test, because of a strong cell-mediated immunity, this is strongly positive. And histamine test show absence of flare reaction. So in the picture, you can see the first picture shows a tuberculoid leprosy macule, a TT macule. Okay, well-defined borders. And the second picture is the depiction of TT plaque, that is the saucer right way up lesion. You can see the periphery, the borders are elevated, and towards the center it is flattened. So after the tuberculoid leprosy, you have the borderline leprosy. So this group of patients, the patient's degree of resistance lies somewhere in the spectrum between lepromatous pole and the tuberculoid pole. And this is subdivided into BP, BB, and BL. So this is highly unstable stage of the disease, and they are more prone for lepra reaction. So the borderline spectrum is more prone for lepra reactions. So in the borderline spectrum, first you have the borderline tuberculoid leprosy. Here the number of lesions are greater than in the tuberculoid leprosy. So up to, and the lesions will be up to, can range from 10 to 20 centimeter or more. And they are asymmetrical. There can be macules and plaques that are well to ill-defined, to irregular borders, and are hypoaesthetic with moderate lock hair. And here the margins may at play stream off gradually into the normal skin. Okay, and another important finding here is presence of satellite lesions. That is, you can see a smaller lesions adjacent to the larger plaque. Okay, and both have a definite different border. So smaller lesion adjacent to the larger plaque. And the characteristics of the surface, they have less scaling, erythema, induration, and elevation when compared to the tuberculoid leprosy. They have widespread and asymmetrical nerve enlargement. Okay, so towards in PT you had a single nerve involvement, or there may be not, there will not be any nerve thickening, but here you have asymmetrical nerve enlargement. More number of peripheral nerves are enlarged. And the lepromine test is weaker, so weakly positive. And in the slit skin smear examination for AFP, you may not get any AFP bacilli, or there can be a scanty. So this picture shows a plaque, and you can see a small lesion adjacent to the larger lesion, that is the satellite lesion. Okay. Okay, coming to the differential diagnosis, the TP and B can mimic a tinea, a cutaneous lupus erythematosus, like DLE, SCLE. Granuloma annulare is a very important differential diagnosis. Secondary syphilis, pityriasis rosea, seborrheic dermatitis, psoriasis, cutaneous TB, that is lupus vulgaris. So there are still more differential diagnoses. I have quoted only a very important differential diagnosis of TP and BP leprosy. So moving forward, in the mid-borderline or borderline leprosy. So this is the rarest type. You may not be able to see this spectrum or this type of leprosy because it is highly unstable. So here you get asymmetrical lesions, which are well-defined, macules, papules, plaques, or a combination of any of this may be seen. And in borderline leprosy, important clinical picture is an annular lesion with this characteristic cis-cheese appearance. That is, outer border is vague, that is lepromatous type, okay? It's not a well-defined border, vague border. And the inner border, it's well-defined. You get punched out lesion. So that denotes a tuberculoid type of lesion, okay? So this is called as the Swiss cheese appearance. And here the sensory impairment will be only moderate loss of sensation. So this is the characteristic Swiss cheese appearance. The outer border is sloping and it's not very well defined, but the inner border, you have a punched out border. And the nerve involvement, you have widespread nerve involvement, still asymmetrical. If it is downgraded from the BT type, it will be asymmetrical. But if it is upgraded from the LL, you get symmetry. Slit skin smear for AF, moderate number of bacilli. And lepromine test here will be negative. Moving to the next spectrum, borderline lepromatous type of leprosy. So this type classically starts as macule, which are small and distinct, variable in shape, and not so perfectly symmetrical in distribution. Okay, so usually it starts as macule, and later they become infiltrated centrally, and they have a sloping margin. Okay, the papules, plaques, and nodules, they have a sloping margin, and they tend to get infiltrated centrally. So this classic plaque lesion has been described as the inverted saucer lesion of Molesworth. It was described by Molesworth. So you have an erythematous plaque with vague outer border and a punched out central. Yeah, so this is the Swiss cheese appearance that can also be seen, and annular lesions, bizarre lesions. So numerous presentations can be seen in borderline lepromatous spectrum. So this is the depiction of this inverted saucer lesion. So you can see the central area is more prominent and the edges are sloping. So this is an important feature to differentiate between the tuberculoid spectrum and lepromatous towards the lepromatous spectrum. So you palpate and see where the lesion is more prominent, whether it is centrally or peripherally. If you have a very well-defined border, the periphery is more well-defined, then it is towards to the tuberculoid spectrum. And if the center is more pronounced, that shows the lepromatous spectrum. So this is very simple. Okay, moving forward. So you have mild loss of sensation and hair in borderline lepromatous leprosy. Nerve involvement is widespread, not so symmetrical. Okay, so in tuberculoid, you had more symmetrical involvement, and here it is getting not very symmetrical. And towards the lepromatous spectrum, that is on the lepromatous pole, you get symmetrical involvement. And here you may start to develop anesthesia, that is the gloves and stocking type of anesthesia. That is the involvement of the forearm, legs, hands, and feet. Okay, peripheral anesthesia. Then slit skin smear for AFP, you may get many bacilli. So the number of bacilli starts to be increasing, and you can demonstrate them in the slit skin smear. Lepromine test will be negative, okay, because of poor CMI. In the lepromatous leprosy, what you have to know, the two types of LL, we already told, the polar type and the subpolar type. The polar type is arises de novo and it is stable, remains there. But the subpolar type, it would have downgraded from any of the lower one, that is the higher immunity one, that is a BT, BB, or BL. Now, what are the earlier identification features of lepromatous leprosy? Nasal symptoms like stuffiness, crust formation, blood stain discharge can be seen. Then edema of feet. These are the early features of lepromatous leprosy. And what about the skin lesions here? So you have very poor CMI. The immunity is not able to, immune system is not able to contain the disease. So it is rapidly multiplying in number. So the skin lesions here are numerous, bilateral, and symmetrical appearance can be seen. Coming to the lesions, it can be macule, papule, nodules are also started to develop in lepromatous leprosy, or you may get a mixture of any of these lesions. And the features of macule, they are ill-defined. Okay, so they are very ill-defined. And one thing I have to tell you is that always examine a patient completely in a very good lighting. Okay, better is the natural sunlight. So this ill-defined body will not be able to make out proper. Need good proper lighting to make out the lesions. Okay, so ill-defined, the macules are ill-defined, slightly hypopigmented, erythematous or copper-colored. And the papules may also be seen, which are seen over the infiltrated skin. And poorly defined nodules can also, these are the common lesions seen in lepromatous leprosy. They are do not have a well-defined border. Okay, so the poorly defined nodules, they are firm and the skin will not be pinchable. So this is the nodules, numerous nodules, which you can see. Also the papules, small lesions in a case of lepromatous leprosy. Another important feature is leonine facies. This is because of the diffuse infiltration of skin of the forehead, and that causes deepening of the natural creases. And that will give a leonine, lion type, lion appearance like that of a lion, okay, leonine facies. Also, the earlobe infiltration leads to thickening of the earlobes. You get superciliary as well as ciliary, that is the eyebrows and the eyelashes. You get loss of hair, metrosis. Also, there can be involvement of larynx, hoarseness of voice. Another important feature is sometimes you may also see ichthyosis, mainly over the extensors of the forearm and hands, and also the thighs may be involved. So you can see ichthyosis that may also be seen in lepromatous leprosy. The type of anesthesia described here is glove and stocking type. And in early lesions, the sensations may be unimpaired, but later on you get anesthesia. Hairs are lost all over the skin except the scalp, because usually the scalp you have hair, so that may protect the scalp from affecting. And what has been described in scalp is called as leprous alopecia. That is, you may get a retaining of hair over the blood vessels. This is because they said to be spared because of the wound given by the underlying blood vessels. So that part may not be affected over the blood vessels. So that is described as leprous alopecia. Okay, this may be seen in advanced stage of lepromatous leprosy. So here the nerves are affected late and there is symmetrical involvement of nerves. And on AFP examination, you see many bacilli with globi formation. Okay, there are numerous bacilli attached together. That is globi formation within the macrophages. Lepromin test is negative. So you can see numerous nodules, then earlobe infiltration in a case of lepromatous leprosy. So what are the BL and LL mimics? There are many. Some of them are secondary syphilis, eruptions, anergic type of cutaneous leishmaniasis, lobomycosis, neurofibromatosis, sarcoidosis, post-Kala-Azar dermal leishmaniasis, the hypopigmented variety, cutaneous lymphoma, the nodules may mimic cutaneous lymphoma. Okay. So we have finished the spectrum. Next is the neuritic HANSEN. Okay, the nerve involvement in HANSEN. So this was proposed by Wade in 1982, and this accounts for 5 to 10% of all patients with leprosy. That is pure neuritic HANSENs. Okay, so there are two types. Okay, first is primary or pure neuritic. The second one is the secondary neuritic. So pure or primary neuritic leprosy means there is nerve involvement without specific cutaneous lesions. And secondary neuritic leprosy, that is in leprosy patients who have skin lesions, had skin lesions before, and they later present with nerve involvement, with only nerve involvement. Okay. And in this pure neuritic leprosy, a spectrum from the tuberculoid TT type to the BL leprosy type has been observed in the histopathology and not the LL type. Okay. And here you get clinically associated sensory, motor, and trophic changes also will be seen. So here in pure neuritic leprosy, sensory involvement will be earlier when compared to the motor involvement. Okay. And the first sensation to be affected will be temperature, followed by touch, followed by pain, and then touch. Okay. So ulnar nerve, median nerve, lateral popliteal, posterior tibial, trigeminal facial nerves are the most commonly affected. And the type of neuritis seen in 60% is mononeuritis. And for the gold standard for diagnosis is only nerve biopsy. Okay. There will not be a cutaneous lesion, but some authors say that even if there is no cutaneous lesion, sometimes when you do a biopsy of the skin, you may find bacilli. Okay, but the gold standard is always nerve biopsy. And this type of leprosy may progress to other clinical forms of leprosy, including indeterminate, BT, and DT. Okay, that is 15 to 35% within 2 years of diagnosis. So that was about neuritic involvement in leprosy. So now coming to the systemic involvement. So system involvement in leprosy may be seen early or even during the course of treatment or even after completion of treatment, because this is a slow nature. Okay, the slow involvement occurs in the systems, and the smoldering nature described, that is the capacity to infect the systems, it remains in a lower threshold for a longer duration of time, and then only it may start to present itself. And there are variable presentations. System involvement in leprosy is most commonly seen towards the lepromatous pole. So always do a general physical examination of the patient in the first visit, or even while on treatment, or even later after completion of treatment, to look for any system involvement. Okay, systemic examination is very important. So system involvement, other than the nerves, the involvement of various organs can also lead to significant disabilities, deformities, and even lead to morbidities. But with the intent of this MDT, there has been significant decrease in the system involvement. So as I told, this can occur after treatment as well. So first and foremost, let's start with the nose and oral cavity. So the earliest sign of involvement in lepromatous leprosy, it's in the nose. Okay, so the clinical features like nasal puffiness, nasal discharge, which can be sometimes blood stained, can be seen in lepromatous leprosy, and this is one of the earliest sign of lepromatous leprosy. And patients in lepromatous leprosy, because of the involvement of the ophthalmic nerve, there can be anosmia, absence of smell. Then edema, there can be insensitive nasal mucosa, edema and mucosal thickening of the nasal septum and the inferior turbinate. Okay, and this leads to nasal septal perforation, nasal cartilage destruction, and along with the involvement of the anterior nasal atrophy of the anterior nasal spine, the cartilage is the first to be affected, and later the bone. So there can be the collapse of the nasal bridge, leading to saddle nose deformity. You can also get papules and nodules on the lips, tongue, palate, uvula, and pharynx, and later this may go in for ulceration. Okay, and later perforation as well. So the involvement of the alveolar bone, loss of maxilla and mandible, the resorption of bone can even lead to easy falling of teeth. Okay, teeth loss. And involvement of the larynx, which is late involvement, it can occur in two forms, fibrotic and ulcerated form, and this can lead to hoarseness of voice and later even stridor. Coming to bone involvement, non-specific, this has been classified into two, non-specific changes and specific changes. Non-specific changes are the most common one, and this can be seen as osteomyelitis, osteoporosis, atrophy, and absorption of bones. The various causes for this are impairment of sensation. So because of anesthesia, because of nerve involvement, there can be repeated trauma, and this leads to trophic changes, and also the restricted muscle movement can also lead to absorption of bone. If you are not using a part of your hand or feet for a longer time, that can lead to disuse atrophy and absorption of bones. Compromised nerve function, impaired blood supply are all the causes described for the non-specific changes in bones. Also decreased because of the testicular atrophy, there can be decreased testosterone in males that can also hasten osteoporosis. So these are all the non-specific changes described in bone. Coming to the specific changes, this is because of the direct M. leprae invasion. There is contiguous spread more than the hematogenous spread. Okay, that is contiguous means from adjacent, from one to the other adjacent side. So from the nerves, it directly bones. So this can present as osteitis, inflammation of the osteum, periosteitis, that is inflammation of the periosteum, bone lytic lesions, then erosions and bones. Coming to the involvement of the eyes, the causes, various causes for involvement of eyes. One is due to the involvement of the trigeminal and the facial nerve. So this can manifest the fifth cranial nerve leads to exposure conjunctivitis, keratitis, and the seventh cranial nerve can lead to lagophthalmos, ectropion, exposure keratitis, and finally corneal ulcer. Also, due to the direct involvement, direct invasion of the Mycobacter leprae, it can lead to supraciliary and ciliary matrosis, conjunctivitis, episcleritis, scleral nodules, then lepromatous pearls, that is a collection of bacilli macrophages seen in the cornea. Then you have superficial punctate keratitis in the cornea. Then iris pearls. These are also the collection of bacilli within macrophages in the iris pearls. The blockade of the nasolacrimal duct can also lead to ductocystitis, conjunctivitis, and corneal ulcers. The ENL type 2 reactions can lead to iridocyclitis, synechiae formation, block the canal of Schlemm, and that can lead to even glaucoma. The nail involvement can be dry nails, hairless or shrunken appearance of nails, and to the end, it may even lead to nail dystrophy. And in the advanced stage, you get absorption of fingers and absence of nails, that is anonychia. The kidney involvement in leprosy is very important to know. There are many non-specific changes. You name any type of glomerular nephritis, you can develop in lepromatous leprosy. Then interstitial nephritis, secondary amyloidosis, pyelonephritis can all be seen. Abnormalities commonly seen are proteinuria, microscopic hematuria. You get RBC cast, granular hyaline cast, increased serum urea and creatinine, and reduced glomerular function rate. Involvement of testis, commonly bilateral involvement, it leads to testicular atrophy. So atrophy of testis is due to the direct bacterial infiltration, or in ENL type 2 reaction, you get inflammation of the testis. And early feature is you get testicular pain and swelling, and then it becomes a firm to hard testis, and finally towards the late stage, the testis become atrophic and shrunken. So the atrophy of the exocrine part of the testis, that is seminiferous tubules, can lead to azoospermia, decreased number of sperms that can lead to sterility. And there is also the involvement of the endocrine part, and that is the atrophy of the endocrine part, that is the interstitial cells of Leydig, can occur late, which can lead to impotence. So last section of today's presentation is the atypical presentations of multibacillary leprosy. So in the multibacillary spectrum, okay, that is the BLLL, mainly in the LL, you can get various atypical presentations of leprosy. So this is very, very, very important to know, because not always you get the classifications of leprosy. So we should have a good knowledge of what are all the various atypical presentations you can see in leprosy. So sometimes in multibacillary spectrum, you may get a single plaque or a nodule or a localized area of nodules or papules may be seen. So then there is this histoid leprosy, where you get multiple nodules. Okay, so we'll be describing it in the coming slide. Then you may get spontaneous skin ulcerations. Okay, so leprosy may present as skin ulcers. Then you have LUCIO leprosy, erythema multiforme may be present. Then lymphadenopathy, which can mimic lymphoma. Long-standing leg ulcers may be a presentation. Leprosy PSEUDOIMBRICATA. So this I'll be discussing. Erythema gyratum repens-like pattern, where you get concentric rings. Verrucous lesion may be described in lepromatous leprosy. Sometimes you may get a dermatomal or a segmental distribution of leprosy. Blaschko-like pattern of leprosy has been described. Sometimes you get only pigment loss. Anatoderma-like lesions in lepromatous leprosy has been described. Tenosynovitis, this may be the only presentation seen in leprosy. So what you have to know is that there are various atypical presentations. So you have to always keep leprosy in mind when you see such atypical presentations. So I'll be discussing few of them, the most important ones. First one is the LUCIO leprosy. So this is seen towards the multibacillary spectrum. So here you get slowly progressive diffuse infiltration of the face and body without any previous presence of any discrete lesions. Okay, so here the skin looks waxy and has a shiny appearance. So this has been termed lepra bonita. Bonita in Spanish language, it means beautiful, beautiful leprosy. Okay, so in this type, you get a phenomenon described that is called as LUCIO's phenomenon. So this is an extensive necrotic reaction because of vascular infarction. Okay, LUCIO's phenomenon. And lepra manchada was an older name of LUCIO phenomenon. Okay. Histoid leprosy, in the multibacillary spectrum, leprosy, you get multiple nodules. So this is a nodular form of leprosy, a close differential for lepromatous leprosy. So here you get smooth, shiny, hemispherical, dome-shaped, non-tender, soft to firm nodules. And this can be superficial, subcutaneous, or fixed deeply under the skin. And the background skin is normal looking. And the important finding here in histopathology is the spindle-shaped histiocytes. Okay, spindle-shaped histiocytes with large number of AFP bacilli. The next one is the LAZARINE leprosy. So this is the one which is seen in the tuberculoid spectrum, okay, borderline tuberculoid spectrum. Here you get spontaneous ulcers of skin lesions. This is proposed to be occurring due to exaggerated hypersensitivity reaction occurring in type 1 reactions. And they may not have a pre-existing skin lesion or any nerve pathology. You get just spontaneous ulcers over the lesions. And the skin biopsy, you can see necrosis due to extreme cellular hypersensitivity. So this is seen in BT leprosy, LAZARINE leprosy. Another one important is inoculation leprosy. So this is the type of leprosy which occurs following scarification or tattooing, also vaccination, needle stick injury. And this was first described by Lowe and Chatterjee in 1939. So what happens here, the Mycobacterium leprae is inoculated during the procedure, and this may lie dormant for many days to years. And later, with the waning of immunity, this may start to get activated, and skin lesion starts to produce at the site of trauma. And this most commonly affects exposed areas because people get tattoos over the exposed sites. And here the spectrum of the disease is more in the tuberculoid TT type or BT type rather than the lepromatous lesions. On skin biopsy, you get compact tuberculoid granuloma with epithelioid cells, few lymphocytes, and there will be plenty of Langerhans giant cells. AFP, usually it is very difficult to demonstrate. And the close differentials for this condition are sarcoidosis, tattoo granuloma, or inoculation tuberculosis, that is lupus vulgaris. Another important feature you have to know is non-trophic ulcers which can occur. So all of you know there can be trophic ulcers in case of leprosy because of anesthesia. There can be trophic ulcer. But there are other ulcers as well in leprosy. So what are the important ones? So there can be spontaneous ulcers in lepromatous leprosy. Also, the histoid leprosy may undergo spontaneous ulceration. Then there is this immune reconstitution inflammatory syndrome, which is associated with intense type 1 reaction in patients with HIV. Then there can be ulcers in reaction, that is necrotic type of erythema nodosum leprosum can occur in ENL. And then you have the LUCIO phenomenon, which has been described. So this is the last one. And this is leprosy pseudoimbricata. So you would have heard this term pseudoimbricata in tinea pseudoimbricata because of the use of steroid. You get concentric rings. Okay. So likewise, this was a case report in 2020. A 35-year-old man with multiple asymptomatic skin lesions on his trunk. And this was initially misdiagnosed as tinea corporis and eczema, and he was treated with topical steroids and antifungals for the past 12 months. And there were multiple well-defined erythematous annular non-scaly concentric rings seen. And the skin, when they did a skin smear, the bacteriological index was 4+, and morphological index was 5%. And on biopsy, it showed features of borderline lepromatous leprosy. AFP was 50. So this is another important rare feature which can be seen because of the use of steroids in leprosy pseudoimbricata. So these are all the various rare presentations of leprosy you have to keep in mind. May mimic leprosy. So always be vigilant, always do a skin biopsy and smear examination to look for leprosy. So with that, I come to an end of the today's lecture on clinical features of leprosy. So this was a vast topic, so I tried to cover most of the aspects in an. Thank you.
Dr. Shwetha has given a very extensive lecture on the clinical features of this. For postgraduates, it is really a very good teaching session. She has covered almost all the aspects of clinical features of leprosy. And you may expect questions in the final year examination on leprosy. So it is always better to study leprosy in detail. Based on the talk, you can very easily cover quickly the leprosy clinical features. And I am sure that all of the students are benefited with the talk.
First of all, we extend our gratitude from ULCERS Pharma to have such a wonderful program, and guest, Madam Shwetha Madam has given lucid lecture to our benefit of our PGs. Almost 55 people were attended across India. Since it is Karnataka, Qtigan is going on, so except Karnataka, all of the states were attended. So thank Madam. Dr. Shwetha Madam has given wonderful lecture on clinical features of leprosy, and we are extending our gratitude to our course that Dr. Ketan sir has given continuously for the past 2.5 years, the continuous series as lecturers for the benefit of our dermatology PGs. So ULCERS Pharma always committed for the always committed for the academic programs, and the winners will be received certificate as well as gift vouchers from our field force. Moreover, the recorded version will be available in our Registers Pharma platform, YouTube channel platform. So kindly get the details from our field force also. Thank you so much and have a great day to all. Happy weekend to all.
Okay.
Thank you.
Thanks, everyone. Thank you. Thank you.